Hello, and welcome to the GAP MASLD MASH Community Network website. My name is Christina Hanson, and I am a nurse practitioner working at South Denver Gastroenterology. And today we're going to be talking about MASLD pharmacotherapy. So thanks for joining in. So currently available treatments for management of metabolic syndrome and MASLD MASH really involve three cornerstones. We want to control obesity, and through weight loss, diet, physical activity, we do now have available various weight loss medications that are being utilized, approved for diabetes, as well as weight loss management. We're going to be talking about these GLPs in a little greater detail, but this is something that we're going to be seeing in this landscape of MASLD and MASH and likely approval of GLPs in the near future. But currently, FDA indications are just for diabetes and for weight loss. So certainly something we want to consider for our patients with MASLD and MASH when it comes to weight loss. Bariatric interventions are also an option for a select population of our patients with MASLD and MASH for weight loss. And then another cornerstone is reduction of cardiovascular risk. So certainly treating those cardiometabolic risk factors and comorbidities, including type 2 diabetes and other types of cardiovascular risk factors, hyperglycemia, hypertension, and certainly dyslipidemia. And it's also important to point out that MASLD and MASH do not increase statin risk of any kind of drug-induced liver injury. We're very used to having patients be referred into our practices by their primary care for elevated liver function tests and or fatty liver incidentally found on imaging, and their provider has stopped their statin. So there is not an increased risk involved with drug-induced liver injury with our statins in our patients with MASLD and MASH. And even in the setting of cirrhosis, if patients meet indication for dyslipidemia therapy, we certainly want them taking their statin. We know that there's data around the benefits of statin at advanced liver disease, including reducing the risk of progression and reducing the risk of hepatocellular carcinoma. So certainly want our patients to remain on their statin. And then the third cornerstone of management for MASLD MASH certainly includes targeting MASH in and of itself. And we have had liver-directed treatment available in the past, not FDA indicated, but studied in the setting of NASH at the time, including vitamin E and pioglitazone. And we're going to talk about both of those a little bit later on, as well as the approval of Resmetirom, which was last year in March 2024, first FDA approved treatment for MASH. And we're going to talk about that as well in greater detail. So first, let's take a little bit of a closer look at these GLP receptor agonists. So glucagon-like peptide-1 receptor agonists. We know that they have been improved in the setting of diabetes and in the setting of weight loss. So after food ingestion, endogenous GLP-1 stimulates glucose-dependent insulin secretion. It suppresses glucagon and delays gastric emptying, therefore promoting early satiety. And it directly acts on the hypothalamus to promote this satiety and reduce energy intake. GLP-1 receptor agonists are analogs of the gut-derived incretin hormone, glucagon-like peptide-1. And GLPs lower blood glucose and cause weight loss. So really the role that we're seeing in studies, and we have many of these GLPs that we're currently researching in research trials for fatty liver. And semaglutide is one of the GLPs that has been more heavily studied and in phase 3 trials. At 2.4 milligrams used once weekly, semaglutide actually successfully met both primary histological endpoints at 72 weeks. And I would invite you to look at the recent publication in the New England Journal of Medicine on these endpoints, these 72-week data. It showed significant MASH resolution without worsening of fibrosis, with an estimated delta versus placebo of 28.9% in treatment arm, and significant improvement in liver fibrosis without worsening of MASH. Again, a delta of about 14.4% versus placebo. So consider administering these GLP-1s for patients that are overweight with MASLD and those higher priority put on those with MASH or fibrosis. This is a population of patients that we wouldn't use it in would be the lean MASH patients. So again, considering it for those that are overweight, that have type 2 diabetes, and a higher priority in those that have more at risk of fibrosis. But as we use these GLPs more and more, how does that affect our patients and therefore affect us as GI providers? We're seeing a lot of referrals for patients who are experiencing side effects related to the use of GLPs, either for weight loss currently or for diabetes. We know and recognize that it delays gastric emptying, and this can be an increased risk of aspiration when we have patients sedated for our endoscopic procedures. So risk of aspiration on anesthesia. And if a patient has taken their dose within 7 days of a scheduled procedure, such as an EGD or colonoscopy, certainly because of this increased risk, we need to consider canceling this procedure. Some practices are requiring longer than 7 days, 10 to 14 days, holding these patients' GLPs before they're performing endoscopy. We had a surgeon introducing himself new to the area come in for kind of a lunch and introduction session earlier this week. And I was listening to his discussion around stopping GLPs before surgery, and a very similar view on it, that he goes for one at the minimal, but up to 2 weeks having patients hold GLPs before surgery. So definitely something that we're going to be seeing more and more as we see more GLPs approved for indication of MASH. So let's talk about some of the agents that have been around, have been studied in the setting of fatty liver, including vitamin E, as I mentioned earlier. And this was studied in the PIVENS trial, which was a landmark study showing that vitamin E improved liver histology in non-diabetic adult patients with MASLD at a dose of 800 international units per day. The indication, and remember, this isn't an FDA approved indication, but the population of patients that you might consider using vitamin E in would be non-diabetic patients with MASH without cirrhosis. And again, remember, in patients that have MASH and MASLD, they tend to have a high propensity to have coexisting diabetes. So this would be for a non-diabetic. In the PIVENS trial, there was an approximate 43% of patients that showed histological improvements. But limitations included that not all patients respond, and we don't want to use vitamin E in patients with hypertension, again, or diabetes. So what are our society guidelines saying? Where are they positioning vitamin E? Well, in 2023 updated AASLD guidelines, they suggest that vitamin E may improve NASH in that non-diabetic individual, while the 2024 triple European guidelines suggest against the use of vitamin E in MASH due to the limited efficacy on fibrosis, actually, and potential risks. So what are those potential risks with the use of vitamin E? Well, there is a potential risk around bleeding and prostate cancer concerns. So we need to be cautious when considering the use of vitamin E in our patients, with a discussion regarding these risks and long-term or higher dose use. And then pioglitazone, another agent that was studied in the PIVENS trial. The PIVENS trial showed that there was no benefit actually of pioglitazone over placebo for the primary outcome, improvement in histologic features of MASH. However, there was significant benefit of pioglitazone observed some of the secondary outcomes with improvement in cardiovascular risk. So there is some consideration for the use of pioglitazone at a dose of 30 to 45 milligrams per day. And again, not FDA approved, but it can be used in a MASH patient with or without type 2 diabetes. Now, safety considerations around pioglitazone, there's a potential weight gain with pioglitazone. So certainly in our patients with MASLD MASH, this is something that is not viewed as positive. They don't want to have further weight gain where they're trying to lose weight. Some risk of edema, bone fractures, especially in our female population, and a possible association with an increased risk of bladder cancer. So again, we need to monitor these patients closely and have a careful selection which patient we might consider using pioglitazone. But last year, as I mentioned, on March 14th in 2024, Resmetirom received FDA approval in conjunction with diet and lifestyle modifications for the treatment in our adult population without cirrhosis, with NASH, as it was studied, with moderate to advanced liver fibrosis. So this is going to be that patient that has stage 2 or 3 fibrosis. We're not utilizing Resmetirom in our stage 1 patient, and we're not using it in cirrhosis as of now. We're actually have ongoing studies of the use of Resmetirom in clinical trials in cirrhosis. But for now, the approved indication is for stage 2 and 3 fibrosis in conjunction with diet and exercise. This is a thyroid hormone receptor beta agonist. We're going to talk about that mechanism of action in greater detail. It selectively binds to and activates the thyroid hormone receptor beta, or beta receptor, in the liver. So THR beta is what we see within the liver. So let's talk about that a little more. The production of thyroid hormones is regulated by hypothalamic and pituitary activity through the TSH, or thyroid stimulating hormone. Thyroid hormones regulate many metabolic activities in several systems in the body, including the liver. And the thyroid hormone receptor has two major isoforms, alpha and beta. And beta is the predominant isoform in the liver. And resmetirom is a thyroid hormone beta receptor agonist that selectively targets the liver. So it does not have systemic concerns or toxicity concerns. It has key mechanistic factors that treat MASH, and this includes its ability to regulate lipid metabolism. So by activating THR-beta in the liver cells, the hepatocytes, it actually upregulates genes that are involved in fatty acid oxidation and lipid metabolism. And this helps to break down excess fat in the liver, so predominantly decreasing intrahepatic triglycerides. It also increases the expression of bile acid synthesis enzymes, promoting cholesterol conversion to bile acids and enhancing cholesterol efflux from the liver. Resmetirom also increases mitochondrial biogenesis, removing unhealthy mitochondria, and this leads to increased capacity to metabolize free fatty acids. So it has pleiotropic benefits in the liver. So let's talk a little bit about the MAESTRO-NASH trial that led to accelerated approval of resmetirom. MAESTRO-NASH is actually an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. And the FDA actually approved resmetirom under this accelerated approval pathway, which allows for earlier approval of drugs that treat serious conditions like MASLD and MASH and address these unmet needs. So based on subpart H, there's an ongoing 54-month study which will assess the long-term clinical benefits of resmetirom, not only in the improvement of steatosis and fibrosis, but also a cardiovascular benefit, reduction of liver-related and all-cause mortality. So that is an ongoing 54-month trial. But in the MAESTRO-NASH trial, this was a study of adult patients with biopsy-confirmed NASH and a fibrosis stage of F1B, but mainly F2 and F3. 966 patients were randomly assigned in a 1:1:1 ratio to receive once daily resmetirom at 80 milligrams or 100 milligrams versus placebo. The two primary dual endpoints, efficacy endpoints at week 52, were the resolution of NASH, including a reduction in the NAFLD activity score, so the NAS score, by at least 2 points or greater, with no worsening of fibrosis. So that was one endpoint. And the patient had to have an improvement or reduction in fibrosis by at least one stage or greater with no worsening of the NAS score. So two efficacy endpoints, dual endpoints. In the MAESTRO-NASH trial, this is the phase 3 safety, diarrhea and nausea were more frequent with resmetirom than with placebo. And the incidence of serious adverse events, though, were similar across the trial. So when we look at breaking this down, diarrhea was seen in about 33% of patients taking resmetirom at 100 milligram, 27% in patients taking resmetirom 80 milligram versus placebo at 15.6%. And diarrhea occurred early in the study and was fairly mild, and I would say didn't last much beyond the first 3 to 4 weeks. And then nausea, when we look at the breakdown, the highest percentage of nausea was seen in the resmetirom group at 80 milligrams at 22%, 18.9% in the 100 milligram arm versus 12.5% in placebo. And then when we look at the phase 3 primary endpoints, we talked about improvement, resolution of NASH with no worsening of fibrosis, and improvement of fibrosis by at least one stage with no worsening of NASH. So in breaking this down, when we look at NASH resolution with no worsening of fibrosis, in the 100 milligram resmetirom arm, we actually saw about 30% of patients achieving this endpoint and about 26% of patients achieving this endpoint in the resmetirom 80 milligram arm versus 9.7% of patients in placebo. And then that secondary endpoint of fibrosis improvement by at least one stage or greater with no worsening of NAS, 25.9%, so nearly 26% of patients achieved this in the resmetirom 100 milligram arm, 24.2% in the 80 milligram arm versus 14.2% in the placebo. So what are some of the practical considerations for managing MASH patients with resmetirom? Our ideal patient is that adult with non-cirrhotic MASH. So we're looking at patients with moderate to advanced liver fibrosis, stage 2 and 3. And this is only approved by the FDA in conjunction with diet and exercise. So we still want our patients working on lifestyle modifications. And other practical considerations, when we're talking about resmetirom, there are some drug-to-drug interactions that you want to be aware of. Avoidance of medications that are strong 2C8 and or OAT-P1B1 and 3. So you can reference the prescriber information for the list of medications that to avoid. But a lot of these types of medications are going to be your antiretroviral therapies, tolerated with resmetirom, but doses that we want to consider reducing, including clopidogrel. So again, I'd have you reference the drug-to-drug interactions. And then medications that are actually at risk of having increased exposure due to resmetirom are possible as well. And I'll notably point out certain statins are recommended to have a maximum dose allowance. So pravastatin, 40 milligram, atorvastatin, 40 milligram, simvastatin, 20 milligram, or rosuvastatin, 20 milligram. We don't want to go higher on those statins. We want to continue to keep our patients treated for their dyslipidemia, but there are some considerations around statins. And that's important because a lot of our patients will be on statin therapy that have fatty liver and could be considered for resmetirom if they're stage 2 and 3. So some other practical considerations for managing patients with initiation of resmetirom is thinking about that duration of treatment and monitoring. There's ongoing evaluation around this as this continues in the MAESTRO-NASH trial. Certainly we'll want to know more about and have bigger set points around the restaging of fibrosis with non-invasive tests. So we're getting baseline fibrosis assessment to know if this patient is indicated for resmetirom at stage 2 and 3. But certainly we're going to want to follow up these non-invasive assessments of fibrosis. So that can include FibroScan with VCTE, elastography, and CAP, MRI with PDFF or ELF. And again, repeating these, what is the interval? And there's needs to be better studies and agreement on what that's going to look for. So expert panels are currently working on these cut points and the intervals for these types of testing. And then there certainly is still questions remaining around the use of resmetirom. Widespread use of it will depend on insurance coverage, clearly, and the periodicity of staging and lab tests for monitoring. And I would reference you to the AASLD's updated guidelines. The updated guidelines around the use of resmetirom last fall and gave an algorithm of where we should consider, again, what patients to consider use of resmetirom in and how to monitor safety as well as response and where to go from there. But certainly we need to understand more on the duration of treatment recommendations and when we should maybe consider discontinuing treatment. And clearly there are multiple other agents currently in clinical trials and will likely have a lot of additional options in the near future. So thank you for joining today and listening in. And if you have further questions, please reach out. Thank you.